Welcome to the GeriPal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we have two guests with us, one Skyping in and one here in studio.
So let's start with the in-studio guest. We have Nathan Brummel, who's a pulmonary critical care physician researcher at Vanderbilt and is in town for the GeriPal Podcast and also happens to be attending the American Delirium Society meeting, which is in San Francisco.
Great. I was just there yesterday. Great meeting.
It is.
Welcome to GeriPal Podcast, Nathan.
Thanks for having me.
And we also have via Skype Lauren Ferrante, who's a pulmonary critical care physician researcher at Yale. Welcome to the GeriPal Podcast, Lauren.
Thanks for having me.
Lauren, we ask all of our guests, do you have a song request for Alex?
Yes. So we wanted to sing a song about change, and so we were requesting Waiting on the World to Change by John Mayer.
All right. We keep on waiting. Wait, let's do that again. Eric, you got to sing too. What are you doing?
I gotta sing too.
Yeah. Well, you got to sing Waiting.
All right.
Yeah, we need it. We need the backup. Let me try again. We keep on waiting on the world to change. We keep on waiting on the world to change. It's hard to beat the system when you're standing at a distance. We keep on waiting on the world to change. All right.
I can't believe you made me sing, Alex.
Yeah, it's great. But that song is actually about how you're waiting for others to change. Is that what you're advocating here when you're thinking about geriatricizing ICUs? Should we be waiting for them to change themselves? Is that the point? No.
So the whole point of the article is that we are advocating that the time for change is now.
Wait. What article are we talking about, Alex, here?
Right. So we should say that the topic of today is geriatricizing the ICU, which is like a critical care medicine. And the title of the article is Integrating Geriatric Principles into Critical Care Medicine. The time is now. And this was in Annals of the American Thoracic Society recently in May of this year. And Nathan and Lauren were both authors on this. Eric, you want to start us off with a discussion here?
Yeah, so we'll have a link to this article online on our GeriPal blog. But we usually like to start off, how did both of you get interested in this subject?
Sure. So it started about 3 years ago at the American Geriatrics Society meeting. There's a medical subspecialties section. And at that breakfast, Lauren and I were sitting together. We're both pulmonary critical care and knew each other through that, but we're at the AGS meeting. And all the other groups were getting up, the cardiology section, the oncology section, and they were presenting all the great work they were doing. And we both sort of looked at each other and said, why not us? We need something like this in critical care. And so from that rose sort of a discussion between Lauren and I. We then put together an application to become a working group in the American Thoracic Society, the largest international group of pulmonary critical care physicians. And over the last few years, that's morphed into an interest group now. So we have a larger group that's working to do these very things of integrate geriatrics and aging research into critical care medicine.
And Lauren, anything to add to that about why did you see this necessary? There was certainly a need there. Anything from your clinical experience that sort of cries out for this area?
Oh, definitely. I mean, I think in the hospital and in the medical schools, we all talk about integration, but we still tend to function in silos, even in the ICU where, we have to manage every single organ system. And actually, the ICU is pretty good at interdisciplinary and multidisciplinary care, but with the growing number of older adults in our country, and, this is something that's been talked about a lot, including on this podcast, I think it just we really saw that it's time to integrate these principles and not just to be calling geriatrics consults all the time. And that's one of the things that we address in the article. And so although we're both researchers, really it was the clinical need for this and, that kind of drove us to form this working group and to address all facets of integrating geriatrics into critical care, research, education, and clinical practice.
So when we talk about principles, what geriatric principles are we actually talking about here?
So we're talking about a number of things. So one of the things that both Nate and I have worked on are vulnerability factors that are present to a greater extent among older adults than they are among younger patients. And these include things like frailty or multimorbidity or cognitive impairment or disability. And many older adults are coming into the ICU with these pre-existing problems. But when we're looking at the critically ill older adult patient, it's extremely rare for someone in the ICU to be thinking about that at the forefront of their mind. We tend to focus on things inherent to the critical illness itself. So something like respiratory failure that's keeping them on the vent. And we're not really thinking about what they're coming in with. So that's just one example where a geriatrician might, be thinking first about the pre-existing vulnerability factors that an older adult is coming into the hospital with and how those vulnerability factors might inform their outcomes. Or their acute illness. And so that's just one example of a principle or at least a consideration that we think we need to integrate into our practice that really isn't being considered in real time in the ICU currently.
Yeah, and I think adding to that, the increased emphasis on outcomes after critical illness, we're seeing things that are classically considered geriatric syndromes like cognitive impairment, disability, and frailty in even our younger survivors. And so there's an added component not only for the older adults, but younger survivors who are suffering with classic geriatric syndromes.
And, of the geriatric syndromes, what do you think is the most common in the ICU? I mean, the one that comes to mind for me, well, I was sort of primed for this, is delirium.
Right.
Does that ring true to you, or is there actually empirical evidence about what's most common?
Yeah, so we haven't studied specifically the types of geriatric syndromes, but delirium being the most common, affecting up to 80% of people that are on a mechanical ventilator.
Wow.
Certainly.
Wait, let's say it again.
Yeah,
80% of people,
80%.
Up to 80%.
Will have at least one day of delirium while they're in the ICU.
That's huge. Yeah.
And that cuts across ages and comorbidities and all these other factors. It's the vulnerability factors plus the insult that critical illness is that brings those two together. And I think the other one that's ubiquitous is immobility.
Yes, definitely.
Every single patient in the ICU is, even though we're trying to get better at that, it's still quite common.
And what sort of what do you think is? There are a couple of historical factors. We started to get into this here a little bit. The ICU's changed over time, right? It used to be younger folks with reversible conditions, right? Like one of my mentees, Brian Block, who I think both of you have met, is writing a piece where he talks about how the ICU's really changed from being a place where young people with polio were on ventilators, and now it's just replete with older adults with dementia often, other geriatric conditions. The demographics and the illnesses, the conditions they're seeing in the ICU really changed over time.
Right. And that's a combination of things. One is that the population is aging, but two is this is the population that's most likely to develop common reasons for ICU admissions, things like sepsis and pneumonia and respiratory failure. All of those sort of track with age as well. And so I think another factor as well is it's not as socially acceptable to deny older adults ICU admission like it once was.
And Lauren, from your perspective, thinking about the level of expertise and awareness of the importance of this issue within the American Thoracic Society, within critical care physicians nationwide or even globally, where do you think we're at? Is this sort of a frontier area, or do they recognize it's important, they have a need, do they already have some training, or is this pretty new stuff to them?
So I think that there is increasing awareness of the need. And if you look back, even I think it was Derek Angus back in 2000 had looked at the epidemiology and the prevalence of older adults in the ICU, and we mentioned that in our article. And at the time, he found that more than half of patients in the ICU were older adults. And if you look at, this is not an official publication, research project that I did, but if you look generally at the number of citations and interest in this area, it has been increasing since that time. And in fact, there's decent interest in mid-career senior folks and also in early career investigators in these specific issues. And the group that Nate described that we created in the American Thoracic Society has only grown. And we keep getting, additional interest from other ATS members. And I think that this is really a growing area. And it is a frontier as far as incorporating these areas into practice. I think that we have seen a lot of progress in research, but we need to see the same amount of progress in clinical care and to continue the progress that we've made in research.
So I'm just going to drill this down to practical issues of what we should be doing. There was a recent tweet that came out saying we have lots of tools for monitoring delirium in all age groups. So what's your excuse for not monitoring brain dysfunction?
Are you saying moderating?
Monitoring.
Oh, monitoring.
Monitoring. Did I mispronounce that? Oops. And there was a ICU doctor who had a rhetorical question. Is it important to monitor something for where there is no obvious intervention to make it better? So the CAM ICU suggests hypoactive delirium. What's next?
Right. What do we do? We can detect it. What do we do about it? Interesting response.
Yeah, so I think it's important that I agree with that statement that we don't have a drug that we could give, which is what we all want, right? We want something quick and easy that we could give a patient. And the problem or the difficult part about delirium is that you have to step back and stop and think about what might be causing it. The average ICU patient has upwards of 11 risk factors for developing delirium, and some of that is related to their underlying critical illness. We recently published a paper that looked at risk factors for delirium, and we called them delirium subtypes. And we identified a bunch of different subtypes like sepsis and hypoxemia, and sedation was one of the ones that we looked at. And we looked at the duration of each of those subtypes, each of those types of delirium. And we found that each of them were related to long-term cognitive impairment. So delirium that people have in the ICU is related to their thinking and memory a year later. And
Oh, sorry.
Yeah, go ahead. Sorry. And so what we found in that study was that of all the causes, right, sepsis and hypoxemia, those don't tend to be reversible, but sedative-associated delirium was associated with long-term cognition, and that's a totally modifiable risk factor for delirium. So it's not necessarily giving something, it's taking it away that may be helpful to patients. And so when you think of that, it's important because it's associated with outcomes, but it's also, you can look for new problems that you can potentially intervene on.
And Lauren, it sounds like you wanted to add to that.
Well, yeah, so one of the areas where we really can improve in the ICU, and many units are working towards this, is the prevention of delirium. And some of the steps that we mentioned in our article include implementing interventions that are already pretty standard on ACE units or acute care for elders units. These include things, we mentioned additions and subtractions from the physical environment. So some additions to the physical environment might include portable amplifying devices for hearing impaired patients.
Yes.
Those devices are not standard right now in intensive care units. I usually find myself looking for one whenever I'm on service, even though we have a pretty aging conscious unit here at Yale. And then other things would be subtractions from the existing environment. So we all know that there's a lot of sensory overload in the ICU and a lot of sleep disruption. And those things also predispose patients to delirium. Mm-hmm. So I think we have a lot of work to do also in preventing ICU delirium in addition to treating it.
And you did a nice job in your paper to break it down into things that we should be doing now, things that we should be thinking about short term, in the next 3 years, and long term. Maybe we can briefly talk about each one of those. So, what should we be doing now to geriatricize ICUs?
So I think the first thing is to start paying attention to these syndromes like delirium and immobility and sensory impairment that are prevalent, because those are modifiable right now, right? Mm-hmm. Eyeglasses, hearing aids, getting people up out of bed are interventions that are effective. And by the way, those at least mobility has been shown to reduce delirium in the ICU. It's the only thing that we have to reduce delirium. 2 separate randomized controlled trials have shown that. The larger term, or the more the short term, the 3 to 5 years and 5 to 10 year goals are things about educating sort of more of the nuances of caring for older adults and treating geriatric syndromes in the ICU. So developing an educational curriculum, research, our research agenda. What gaps in knowledge do we have about caring for older adults? We actually submitted a proposal to review the literature, and one of the comments we got back was, well, we all know that there's nothing there.
There is no literature.
That's our point. But
right, that's the point. Yeah. Lauren, you want to add to that?
Yeah, so, in addition to training pulmonary and critical care fellows to really consider these geriatrics principles, especially as they become attendings, I also like to think a lot about what can we do with the current practitioners in the ICU. And I saw a recent paper, I was just trying to find it, I think it was out of the UAB group, where they talk about virtual ACE units, and where they're basically going around to different units and training the existing practitioners. And I wonder if that might be a more practical model for early implementation. And so although we outline a number of, I think one of the things we mentioned, are just in-service trainings, things like that. But I think we can't lose sight of the fact that we have to train our current practitioners so that they're thinking about, these concepts in real time. And the other thing that we mentioned for the future is and this is something Nate and I have talked about a lot, is creating a network of aging intensivist researchers, because one of the areas that we outline in the paper is that many clinical trials and studies in critical care medicine often exclude the oldest old, or don't have critical numbers of older adults. And we're hoping that our group, which has a lot of critical care researchers in it, will one day, as we go from the K to the R phase, we'll be able to have an aging intensivist network so that we can answer some questions about how to best treat older adults in the ICU.
Is there a reason for that lack of inclusion of oldest old into ICU research?
So from a practical perspective, it's not that the study exclusion criteria say if you're over 85 or 90, you can't be in the study. It's that they exclude people with multiple comorbidities or cognitive impairment from their studies. And so they sort of de facto exclude older adults.
Right.
I wanted, you want to follow up on that, Eric?
Go ahead.
Well, it does seem like this is the bait and switch that often happens with clinical trials, that they test it in a very select group of sort of healthier individuals in order to show efficacy, but then they roll it out for people who have multimorbidity, dementia, functional impairment, real-world, oldest old type of patients, and we have no idea whether it works in them or not. So I love this idea of setting up a trials network to actually study this effectiveness in real-world settings.
Right.
Mm-hmm. And some of the demographics of the existing trials and, near future trials may change now that the NIA is mandating inclusion across the lifespan with that new policy, which I think is going to be effective next year. But we still feel that there would be benefit to have this aging intensivist network. So that's in the longer term plan.
Right.
And is there... You've probably been to a lot of ICUs. Is there a design element to ICUs to make it more age friendly?
Are you talking about architecture?
Yeah, like the way ICUs are designed. I mean, when we think about ACE units, not just mobile ACE units, but like physical ACE units, a lot of times we also think about the design of those ACE units. Is there room for family members to be there? Is there room to actually do things like get up out of bed, walk around?
Right.
Is there light coming in from the outside? Are the bathrooms easily and accessible? Like, what are your thoughts about that?
So I don't know from a national perspective, but at Vanderbilt it's when I was a fellow, so it's longer ago than I care to think about, but it was that we opened a new critical care tower that incorporated a lot of those things you just talked about. There's space for the family to stay with the patient. There is a bathroom that's accessible. It's a very large open space compared with our old ICU, which you had to be an acrobat to be able to maneuver around all the equipment and the bed and everything like that. There may have been a chair in the corner for a family versus a pull-out couch or something for them to sleep on. And so I think those are important things. And we know from demographic data that the number of ICU beds, even though the number of hospital beds nationally is decreasing, the number of ICU beds is increasing. And so whether that's conversion of existing hospital beds into ICU beds or construction of new ICUs, but I think that's a very important point for hospital administrators and architects to keep in mind as they design these spaces to make them aging friendly.
Yes, and we also have a new unit at Yale, so we also have, space is definitely not a problem. There are huge windows, lots of light, but there are some things inherent to the ICU that aren't contingent on space that I think probably every ICU in the country could improve on, and that one big problem is noise. And also sleep disruption. So we have a group here at Yale that works on sleep in the ICU, and they measure the noise in the ICU, and especially in certain rooms. It's just because the monitors are outside in the hall, it can be really, really disruptive to the patient and disorienting, and you can see how that might predispose to delirium. And the other problem we still have in every ICU, I think, is a tethering problem. Mm-hmm. So I often start talks that I give with a picture of a patient in an ICU bed, just so that the audience can really grasp what that looks like. There are telemetry wires, multiple lines, central lines, Foley catheters, sometimes CVVH, and the tethering devices, although despite our best attempts at early mobilization, they can still be problematic, especially for older adult patients.
Yeah, I think about our ICU, the monitors are in the room. There's always at least one monitor beeping. And if it's not the monitor beeping, it's the IV beeping, fluids. Right? The fluids are beeping. So there's always a beep. There's at least one beep, if not two beeps. The television is on. They got the airbed. And the airbeds these days, the best airbeds are wonderful for your skin. But the decibel level of the airbed is off the charts. You can hardly hear. I feel like I'm on an airplane with all that background noise. I need noise-canceling headphones. We tried to have a meeting with an ICU patient the other day. We could hardly hear anything. And we're not 88 years old with hearing loss. So I can imagine just such deliriogenic, just sort of setting for older adults.
It's a harsh environment for sure.
So from a design issue, it should not be that hard to have the alarms transmit outside or to the nurse somehow or on their mobile heartbeat. All the practitioners in our units are now connected through iPhones. And so from a design standpoint, there's really no reason that alarm should be going off next to the patient's head as opposed to on our personal device. So hopefully, we can break. Maybe engineers need to start working on that. I don't know.
Oh, yeah, the medication pumps. Those are the worst because they all around the hospital. They just go off. They go off for 10 minutes before somebody can walk into the room and turn it off. I just know the little yellow silence button, but that only lasts for a minute.
Yeah, and then you got to push it again, right?
Yeah.
Well, is there anything else that you guys would like to talk about before we end?
Yeah, well, I have a question for both of you as geriatricians. So how do you read our paper and you've seen that we think we need to integrate the principles of geriatrics into critical care medicine, but we certainly, want to keep our geriatrics colleagues involved in the ICU. And, do you think that this is a good idea, integrating it? Do you think that it's problematic from a geriatrics consult standpoint, or do you think we would work together on this type of initiative? How do you foresee it from your end?
Yeah, I think I love your analogy or the idea of bringing an ACE unit into the ICU because, if you look at a lot of ACE units, they're not taking over care. They're often just focusing on key geriatric syndromes for those individuals, making recommendations on that. They don't need to be heavily involved with every patient, and sometimes it's just a quick touch point. And I can imagine the same thing happening in the ICU. I think the challenge is how do you actually staff that in hospitals. But I think if we think about interprofessional teams in ACE units, it's a reasonable and attainable goal to actually get. So you don't have to do full geriatric consults on every ACE and every ICU patient, but you just develop a system where you can have those quick touch points.
Mm-hmm. And I'd just add to that to say that I think, Eric, you're more in touch with these data than I am. The number of fellows, geriatrics fellows, clinical geriatrics fellows, has remained relatively flat.
It's been relatively flat
for a period of time.
Yeah.
And there are a lot of older geriatricians who are retiring are approaching retirement age. And I guess what my point is, there is no way that there's enough of a workforce of geriatricians to meet the demand in the ICUs, and so the primary focus should be on primary geriatrics delivered by critical care physicians in the ICU, and education of those physicians, changing the environment, education nurses, and the whole interdisciplinary team.
Yeah, I mean, part of me also thinks that's. I think we can harp a lot on the geriatric workforce issue and why things can't happen, and in some ways, that's probably not where we want to start. Like, we can make this change. The workforce is there. The workforce is there from a specialty geriatric standpoint. The workforce is there from a interprofessional geriatric standpoint. Again, if you're in most ACE units, it's not just the geriatrician. It is the nurse with geriatric expertise. It's the physical therapist. It's the pharmacist. Like, it's a team of individuals. And it's also, like you said, making sure that we are also educating great primary geriatric skills for ICU providers. Not just physicians, but the whole interprofessional team. So I do think the workforce is there. We can do this. It's just getting bright people, eager people like the people we have on this podcast to actually make that change. Not waiting.
Don't wait for the change.
Be the change. Be the change. But I think you raise a very good point about that, where, Lauren and I and others around the country and around the world really are approaching this from a critical care perspective. But I don't know that we've really engaged our geriatrics colleagues to say, hey, let's sit down and figure out what that primary geriatrics for the ICU really looks like, and how do we train people in that. I think that's a very good point that you raise.
One of our listeners out there, or many of our listeners out there, is listening right now, and you're thinking to yourself, I want to get involved in this. I'm a geriatrician. I do a lot of consults in the ICU. I see the issues they're talking about. This all rings true. Contact Nathan, contact Lauren, get involved. We need geriatricians to have input on this issue.
And I think there's lots of great analogies, for instance, like geriatric EDs, emergency departments, like learning lessons from the places where this has been implemented, both delivering specialty geriatric care and also in like geriatric EDs. It's a lot about primary geriatric care from physicians and nurses and everybody else involved, and also design, like thinking about how we design these units, whether EDs, ICUs, or hospitals.
Absolutely. And just to anyone who's listening and is thinking, I want to be involved, but I don't know when I'm ever going to see an intensivist and I'm not going to the ATS meeting, we do have a group in the American Geriatrics Society called the Medical Subspecialties Section, and these are exactly the issues that we work on. And so if you email me or look in the program at the next AGS meeting, you should come talk to us. Even though the section is called the Medical Subspecialties Section, we actually invite everyone to come, surgical subspecialists, geriatricians, and these are the issues that we want to be talking about and working on. And again, that's where this group started. The group that Nate and I formed was actually at that meeting.
Wonderful. Well, I want to thank both of you for joining us at this GeriPal podcast.
Thank you, Nathan. Thank you, Lauren.
Thank you, Alex.
Thank you,
Eric.
And Alex, how about you end with a little bit more of that song?
Me and all my friends, we're all misunderstood. They say we stand for nothing, and there's no way we ever could. Now we see everything going wrong with all the world and those who lead it. We just feel like we don't have the means to rise above and beat it. So we're just waiting on the world to change. Keep on waiting on the world to change. It's hard to beat the system when you're standing at a distance. We keep on waiting on the world to change.
No more waiting, right?
No
the
more
change
waiting.
Is now. Well, I want to thank all of our listeners for joining us. We look forward to talking with you next week, and thank you to our guests.
Thanks for having us. This was fun.
Thank you so much, Lauren. Thanks, Nathan. Appreciate it.